To some of you, I think I spoke yesterday at the lab. To others, I didn't. I'm Andreas Kumal. I'm from HSS. You met Sabrina. We've been married for a while. And we do similar things, but not exactly the same things. One of the problems, and I'll apologize in advance, is there's certain things, there are many things that may be available in the US that are not available in your countries. So I hope you take this as sort of an interesting overview of certain things you can do, certain things you may not do. I hope that part is not frustrating, but stimulating to see what's out there. And there are ways for you to maybe get some of these techniques to your country, especially when it comes to osteochondral allografts. But I'll talk about this in a little bit when we get to that talk. So in thinking about what to talk about in your program, you'll see we'll talk about cartilage repair, we'll talk about meniscus transplantation, we'll talk about osteotomies. I will end with osteotomy. I think that is almost universally applicable to most of you. And maybe you use different plates, but the techniques you can do anywhere where you have sort of a large frag osteosynthesis set. So I figured we'd talk with cartilage repair, and cartilage repair for kind of what I call in this one the simple small defects, because those are just the most common ones that might be the most interesting. So what are simple small defects? It's the one on the top right. It's not the knee on the bottom right, which is, actually that was a woman in her mid-30s that just has cartilage defects everywhere. This is after debridement, but obviously we're not talking about simple defects as that. In terms of disclosures, I work with a lot of companies on developing new implants. Some people joke if you talk to a lot of companies, then you're equally conflicted into all directions. I think I'm pretty equally conflicted, mainly because I talk about cell-based, which is something like ACI, in this case Vericell, but I use a lot of osteochondral allografts, which would be JRF. So I think the most important thing with cartilage repair, as with many other things that you do, yesterday we talked, for example, about graft choices for ACL, and at least in the US, people tend to be very dogmatic. So a lot of people stand on a podium and say, you must do this, you must never do that. There's really I think, no place for that in medicine, because sometimes you will see someone who it goes against the grain and maybe you want to do this, but for whatever reason you have to do something else. So keep an open mind. There are many options, and having many options can be confusing, both to the physician and the patient. And I think some of my colleagues find it easier to be dogmatic and only do the one thing, because that makes the discussion very easy, because there's no discussion. There's just, if you need an ACL, you do a patella tendon, that's it. Cartilage repair has a lot of options, as you'll see in a moment. And I think being dogmatic makes for bad care, because there's always a spectrum of disease. And if you only have one answer for a little problem or a big problem, that means you either overtreat or undertreat. So if there's nothing else you take away from this day, is trying not to be too dogmatic, keep an open mind, look at new procedures. And I'm not trying to sell you a specific procedure, because I do most, if not all of these. So what is small? In the US, at least, there's sort of an easy answer to that. Anything less than 2 square centimeters is small. There's nothing magical about this 2 square centimeter besides, and that's why I say in the US the answer is easy. Our insurance companies consider 2 square centimeters as the threshold above which they actually pay for the bigger procedures, the osteochondral allografts, the ACI. Anything less than 2 square centimeters, they will say, we don't pay for this. You can do little things that are cheap, but you can't do the expensive things. That's why when I talk about these, I usually group them in 2 square centimeters. From a medical perspective, as I said, there's nothing magical about 2. So nobody should really argue if it's 1.8 or 2.2. It's just 2 is a round number, so insurance companies use that. But I think it's useful to think about this 2 square centimeters, that's roughly 1.4, 1.5 centimeters in diameter. And that's actually a very common defect size that you may see from failed ACLs, patella dislocations, so a lot of defects. I would say at least over 60 or 70% of all defects will be in this size range. So that is a useful definition. So what can you do for these small defects? Debridement is the easiest thing. Chondroplasty, we've had that forever. You stick a shaver in and you make a cartilage defect, which in the US, trying to relate to my patients, I use a lot of analogies. I use the analogy of a pothole in a street very often because that's sort of what these things look like. Everyone, unfortunately, has seen potholes. And the analogy for doing a chondroplasty or debridement is that you make a pothole into a nicer pothole. So when you look at a pothole in the street, it usually has sort of jagged edges. There's some beaten up pieces of road, gravel at the base. And these cartilage defects in the knee oftentimes look very much the same. So you may have things floating around in the joint. You have flaps of cartilage at the edges of the cartilage defect, and that gives you mechanical symptoms and pain. You can make the pothole nicer, so you smoothen the edges a little bit. You make sure that there are no unstable flaps, but at the end of the day, you still have a pothole. But in discussing with patients, well, then why do we do this? Why do we not fix the pothole? This is a very easy operation. It's cheap for the system. It's easy for the patient to recover. It's easy for you to do. And sometimes that may be enough. So if you have someone who comes in and says mainly the knee is catching, they have mechanical symptoms. I had a cartilage flap in my elbows. Every time I reached for the mouse, it would kind of catch, and I had to shake my arm to get to the mouse. I can tell you it's really annoying. I didn't have a cartilage transplant, I just had a chondroplasty. It still hurts a little bit, so I still have that pothole, but at least it doesn't catch anymore. So kind of mission accomplished. I had that surgery on a Tuesday, and the next week I did 22 cases. Easy recovery, you can get back quickly. So even though it's not very satisfying for us who are maybe a little engineering mindset to leave a hole behind, but at least every system will allow that. Now, if you take the next step and say, well, we have a hole, but we want to fill the hole, most medical systems will allow you to do what used to be a microfracture, and we still use the term microfracture a lot. It probably should be bone marrow stimulation, because at least in the US, we've moved away from taking that pick and using a mallet to really do a microfracture, and we've moved to bone marrow stimulation and subchondral drilling. So for the most part, I would say if you want to do this, take a K-wire or a thin drill bit, like a 1 millimeter drill bit, do multiple drillings. Why is that? Because with the old pick, you actually cause microfractures, so the name makes sense. But what happens to bone when you fracture it? It heals, it forms callus. So if you look at outcomes of microfracture, if you look at MRI scans, CT scans, long-term, patients form a lot of what's called intralesional osteophytes. The subchondral plate looks abnormal, it gets very thick, they form cysts. And that's because if you look at what happens when you put that pick in, you don't only have a hole, but you have cracks that come out from the hole, and that injures the bone, and then the bone reacts with bone formation. So instead of getting fibrocartilage, a soft tissue, you may end up filling the hole just with bone. And that may hurt just as much as if you have an empty defect. On the other hand, if you drill, at least if you drill arthroscopically, because here you have water, you don't cause thermal necrosis of the bone, is a much cleaner thing. You remove some of the bone, you don't compact the edges. It makes it much easier for bone marrow to actually come out of the hole, which is what you want. Whereas if you think about what the pick does, it doesn't remove any bone, it just compresses the bone to the side. It might actually plug up the bone around you. So if anything, drilling is better, thinner is better, deeper is better. So trying to go a centimeter or so in depth is very helpful. The next one is micronized cartilage matrix. Generally, I try and avoid trade names if I can, but this is a somewhat complicated name. Arthrex has a product essentially where they freeze dry cartilage. It's the extracellular matrix. They micromill this. It's a powder. You can mix that with PRP or bone marrow or blood, and you can paste it into the defect. There's some studies that show it helps, not that many studies. It's fairly cheap. In America, it's been used more frequently in addition to microfracture or drilling. So you drill, and then you add that as a paste to the defect. The sense is that it gives you better repair tissue. As of yet, it's not very supported by data, sort of a feel-good thing. Autograft cartilage is something that we don't use very much in the US. I'll talk about this in a moment. Oates, mosaicplasty is, I think, probably of all the cartilage repair techniques, the best. It's also technically probably the most challenging on this slide. And in our hands, we only use it for the really small defects. So more to that in a minute, but usually give like 1 or 2 plugs. The concern in the US is if you use a lot of plugs, then you have a hole here that you fill, but by filling this hole, you create a lot of holes on the side of the knee, so you move the problem from one area to another area. So there's donor side morbidity that's a little bit of an issue. And then the last one, similar to this micronized cartilage matrix, I don't know if it's available in your country, but this coral implant, it's called Cartilage. It's an Israeli company. They did studies in Europe. In the US, it's on the market. They want to bring that to the market, the rest of the world. So the reason mentioning this is because you may actually see that in the next few years. But I'll talk in a little bit more detail on the next slides. So this is an example of sort of a small defect. And I think cases are most helpful because then when you see a patient, maybe you remember, Gomal talked about this at some point, and I remember the pictures rather than doing flow charts of what do you pick in what patient. So she's 26. She's a pretty high-level lacrosse player in the US. High school, college, usually by 22 you're done with college. And America is a country of extremes. You have probably the fittest people in the world. When you look at kids in high school, I know you look critical. That's why I said extreme. If you look in high school and college, everyone plays sports. The guys are all incredibly fit, and then as soon as they are done with college, they keep eating the same, they just don't work out anymore, and then all of a sudden we're the other extreme, we're the fattest country in the world. But lacrosse is something that some people still play after college. She's certainly not fat. She did this at a high level, and she had a pivoting injury where she was doing her normal thing, non-contact. Kind of the story sounds like an ACL, but in her case, she had this injury that you see up here on the sides. So she has an acute delamination of lateral femoral condyle articular cartilage. And on this one, it looks really big, but when you look at the arthroscopy picture, it's big lengthwise, but it's not very wide. So in her case, I ended up doing 2 overlapping Oates plugs. Lateral condyle is actually a nice location for this because you can make 1 incision, and I do Oates with a small incision. I don't do it arthroscopically. You make 1 incision and you extend the knee. That puts you over the lateral trochlea, so you can harvest the plugs, and then you flex the knee. It brings you over the defect, and you can harvest an implant through the same incision. Technically, you can take plugs if you need multiple plugs from the medial trochlea, and there were studies that looked at where is the highest and the lowest pressure in the knee joint, and actually the lowest pressure is in the proximal medial trochlea. The only time I would recommend doing that is if you have a larger guy. So if you have someone who's 175 and above, the medial trochlea is big enough for you to do that. But if you look at a woman in the 155, 160, the medial trochlea is really small. And if you take even 1/8 or especially a 10 millimeter plug, that might be most of the medial trochlea. So in that case, I would be kind of careful. But in her case, so 2 plugs, they were 8 millimeter from the proximal trochlea. Now, why do that? Because we have good data that Oates gets you back to sports or to life the quickest, because you have primary bone-to-bone healing. It's your own tissue. It heals the best. But we could have done other things. So what would have been the alternatives for this one? If she were playing, it is in season, she wants to get back to playing as quickly as possible, and her main issue were just like the elbow or something's catching, then you could have just done a debridement and she could have gone back maybe in 10 to 14 days. With this one, not so much because of the plug area, but the harvest area, it still costs you 3 to 4 months before you go back to sports. So a little bit longer recovery, that's sort of a season-ending surgery for the most part. So debridement would have been one thing. If the issue weren't mechanical symptoms mainly, but pain, then you can do the drilling, as we talked about. You can do this if you have it, micronized allograft, autograft cartilage, or a coral plug, depending on what's available. But I would say worldwide, everyone has drilling, everyone has oats, everyone has debridement. So those three options would have been fine, depending on what her main symptoms were and what she wants to do mostly after. There's another patient. You've heard a lot about patella dislocations by Sabrina. There's a 22-year-old, multiple dislocations. She has this typical medial patella facet cartilage defect that you can see here is some edema, maybe a small little cyst here. This is what that looked like. In the US, we have ACI or MACI. That's usually what I would do for something that size. We also have something that you see here. Those are little chopped up pieces of cartilage in a fibrin glue matrix. In the US, we use allograft. Worldwide, what you can do is autograft. And that has become increasingly popular because, again, it is cheap, it's available, and there's good and increasing data to show that it works. So what do? You debride the defect, and there are studies that have shown that even though the cartilage along the periphery doesn't look good and it's not mechanically stable, so it's not very useful, but if you debride this and make this sort of into a nice pothole, as we talked about, all the cartilage that you debride, keep that on the back table, chop it up into little cubes, a millimeter thick, harvest some extra cartilage from the notch, where you would do, for example, during ACL, a notchplasty, or you can get some extra cartilage from the proximal medial or proximal lateral trochlea, where you would harvest an oats plug. So you can get enough cartilage that you not micronize, but you chop with a larger blade. You mix it either with fibrin glue, or you can mix it with bone marrow aspirate that you clot. The clot goes in. Fibrin glue is usually enough to keep that in place. I wouldn't necessarily trust clotted bone marrow. Many of you might have something like a chondroguide membrane available, then just suture that over it. I wouldn't do anything to the bone, because even though I said drilling is better to bone than microfracture, if the bone is intact, if you don't have to mess with the bone, that tends to be better. So with the bone marrow, you can bring bone marrow stem cells into the defect by just aspirating from the iliac crest, the proximal tibia, or the distal femur. But you don't have to mess with the local bone, which sometimes, even though you don't microfracture it, even with the drilling, sometimes it forms these internal osteophytes. So this, I think, is a really useful technique, especially for the patellofemoral joint. Square that away somewhere in the back of your mind. If you don't do it, it's autograft cartilage, and especially if you do it open here, it's very easy to just harvest it with a scalpel and mix it with either fibrin glue or bone marrow. I just briefly want to mention, because this, in the next few years, you will see, because it's an off-the-shelf, it's comparatively cheap. This is actually a true coral from the sea, harvested. If you look under the electron microscope what coral looks like, it's a very similar ultrastructure and chemical composition to human bone. It's almost indistinguishable. And human bone seems to like coral. It's been used years past as a kind of bone graft substitute in trauma surgery to fill bone voids for osteotomies. So this is perforated to really help bring bone marrow up to the surface